everyone. Thank you for joining today's webinar on Medicaid Unwinding, the current state, best practices, and future vision. I am Rebecca Pressler of the Managed Care Resource Alliance, and I'll be moderating today's insightful discussion on this important topic with our speakers. Before we jump into today's content, I have a few housekeeping items. Attendees will be placed in listen-only mode. We'd love to make this interactive though, so please feel free to ask questions throughout the presentation using the Q&A. Just enter your questions into the chat box and they'll be answered throughout the session or during the Q&A at the end of the webinar. So now I'd like to go ahead and introduce today's speakers. We're joined today by Yvonne Doherty, the Global Head of Industries for Usher. Yvonne brings more than 30 years experience in healthcare via leadership roles in marketing and communications, including 6 years at United Healthcare in demand gen marketing, broker, employee, and member communications. Throughout her career, she has specialized in more effective and influential communications that drive engagement, better experiences, and better outcomes. Yvonne leads the healthcare strategy and go-to-market at Usher, serving as the bridge between the business and the market. She's also Usher's subject matter expert for member engagement and activation best practices, working with clients around the world to implement more effective omni-channel B2B and B2C communication. I'm also joined today by Barry Vollen, the co-founder and CEO of the Managed Care Resource Alliance, or MCRA for short, and he's the president and CEO of BV Consulting. Barry's professional career spans over 35 years, specializing in managed care operations and consulting. He's served in a variety of executive roles for various Medicaid, Medicare special needs plans, managed long-term care, and fully integrated programs, and has been successful at program startup, management, growth, and service area expansion, process improvement, and financial turnaround. His areas of expertise, they include organizational leadership, startup operations, innovative and creative solutions, team building, cost reduction and operational efficiencies, marketing and sales strategy development and implementation, and value-based contracting or pay for performance. Barry represents the health plan perspective in today's challenges for MCRA, and he leads MCRA members in dialogue as they collaborate to develop innovative solutions to the managed care challenges. And before we jump into it, I'd just like to quickly go through today's agenda. We're going to be reviewing the history of Medicaid unwinding, today's reality, going over the silver lining, the new normal, and we'll end with a Q&A. As we get started, Barry, I'll turn it over to you.
Thank you, Rebecca, and thank you, Usher, for having us here. I wanted to start by setting a contextual stage for our discussion and lay out, how did we get here? How did this mess get created? And oftentimes we look at this as starting with the public health emergency as a result of COVID and the pandemic that started back in March of 2020. However, me personally, I've been involved in Medicaid managed care now since the mid-1980s. And I remember we used to scratch our head every month as we tried to do reconciliation around enrollment. Every month we would add all of our new members to the plan. We would subtract all of those that voluntarily disenrolled. And assumedly, we'd come out with our new membership. But there was always a missing factor, and that missing factor were those members who would leave the plan due to involuntary disenrollment, typically tied to recertification issues. So the recertification issue it's not a new issue. It's an issue that has just not been overlooked, but has just been part of the woodwork over the years. We've managed it, we've processed it, it's just been a reality. What's happened though, in March of 20 with the pandemic, there were a number of exemptions that were put into place by CMS that essentially waived the need to recertify during the course of the public health emergency. In April of 2023, the public health emergency essentially ended, which ended back in 2022, December of 2022, but terminations started as of April of 2023, based on recertification issues. What we were facing then was this huge bolus of members that had been extended throughout this public health emergency period, almost 2 years, through almost 3 years, and now facing not just those individuals, but those individuals who were currently active in our plan and requiring recertification moving forward. That sets the stage, but then there were additional mitigating factors that created an even bigger problem. Could we go to the next slide?
Barry, before you go, there's
Yes.
actually a question in the chat. So the question is, when do you think this redetermination process will actually end?
Boy, that's a great question. And I wish I had the definitive answer because I'd be investing my money elsewhere. Um, the long and the short answer, in my opinion, is that until we see some sea change in how the processes are managed, this is going to be an ongoing problem. We will be able to resolve, we'll be able to chip away at it, but will it go away? No. And what I'd like to do is hold back a full answer until the end of this presentation and give you a vision of what both Yvonne and I see as a future. And I think it's only when we reach that point in time that we can comfortably say that most of this redetermination issue is behind us. Okay, Yvonne, I don't know if you want to add anything to that, but
No, I absolutely agree. You mentioned this has been going on for well before the pandemic, well before the public health emergency. Renewals and the dropping for administrative reasons is going to continue. We're in this huge mess, as you said. And I hope we're going to be able to learn a lot of good lessons so that in the new normal that we'll talk about later, it will be less painful for everyone. So.
Okay, can we go to the next slide? So, a perfect storm is defined in the dictionary as an event arising from a rare combination of adverse factors. And I think back to the Mark Wahlberg movie, and I think if ever there was a time, we're in the middle of a perfect storm now when it comes to Medicaid redetermination for a variety of factors, not just those that I've talked about, the pandemic, but other factors. We've already talked about the populations that need to be processed. But in addition to that, this has been a population that historically is incredibly transient. It's hard to manage members who are moving from one address to another address, whose financial situations are changing daily, weekly, monthly. That becomes an even more slippery slope. Add to that the change in work culture throughout the course of the pandemic, people working at home rather than in offices, and the resulting staff shortages in areas and areas that require people in the office. So what we find ourselves now in is this perfect storm. We've got this huge bolus of members who have lost eligibility historically. We've got members that are currently in the plan that are going to be losing eligibility unless they get recertified. We've got a population that's moving. And if we look over the course of the public health emergency, there was a lot of outward migration from a lot of states to different states of people, Medicaid eligibles as well as others. And then factor in staffing issues. Staffing issues at the state has created significant delays in some cases of applications and application processing. So even if the plan and the member actively pursue recertification according to the old rules, the process delays are significant. And if we go to the next slide, I'm just going to highlight 5 states and give you some indication of what the delays look like. New Mexico, right now, 45% of all applications that are processed in New Mexico are taking more than 45 days to process. Similarly, in Missouri, 34%, 32% in Texas, and so forth. So in the old days, pre-pandemic, we were seeing applications turned around in under 30 days. Now we're seeing almost half of the applications taking in excess of 45 days and longer to get recertified. So you've got staffing, you've got this huge bolus, you've got transiency. It's created a real issue of where we are today. Can we go on to the next slide? The impact of this has been significant, and I'm gonna leave this to Yvonne to go through what the sheer impact has been.
Yeah, thank you so much, Barry, for setting the stage and giving us the history. And really, between 7.8 million and 24.4 million people, adults, children, families, the most vulnerable populations, could lose Medicaid coverage during this unwinding period. That is such a huge human toll. In addition to the MCO, the plan impact 8 to 28% decline in enrollment. So I call it the perfectly imperfect storm that we're all living in. And you can go to the next slide. I'll just go back a little bit more into the current impact. So during just this first 6 months of unwinding, more people lost Medicaid coverage than in any period, 2-year period in American history. So unprecedented loss of important healthcare coverage. More than half of the 10 million people were terminated, and they came from communities of color. And this is a time when everyone is really rallying around health equity and access. And so this just hurled itself in on top of all of those efforts. And then this one is just so shocking that the more than 70% of the people terminated may still be eligible, but they didn't get their coverage because of missing paperwork or red tape. So huge impact nationwide. You can go to the next slide. I just wanted to hit the headlines are just so brutal. And you can really see here the Medicaid unwinding harming millions of people, especially communities of color. Nearly 400,000 New Yorkers purged from Medicaid for paperwork issues. Hundreds of thousands denied Medicaid and food assistance in Texas. These are hard-hitting headlines that really just showcase the suffering, what is happening around all of this perfectly imperfect storm. And the silver lining here, and we're going to go into what has been identified by multiple sources as a big root cause that we can all rally around. Right now, as Barry mentioned, what was happening or what is happening to address this problem, to get people to actually do the application process, it's being solved by old solutions and methods and data and limitations with staffing, and expecting these old things to have a different result, which is really a bit the definition of insanity. But we are seeing some great efforts and some things that are being done within the MCOs that are helping with the root cause of a lot of what's happening. The root cause here, according to Kaiser Family Foundation, is a lack of awareness due to ineffective member communication. Members still simply do not know that the states are now permitted to resume disenrolling them. They don't know they have to take action. So unless effective communications can get to them, educate them, and hold their hand until they take the action, this is still going to be an ongoing issue, the disenrollment and people getting dropped.
Yvonne, can I make two comments to this?
Absolutely.
One is on the communication. Having worked in health plans all my career, communications are usually designed around compliance language and regulatory language, and oftentimes is sent out to addresses that are provided to the plans by the state and or the county. And quite frankly, they don't have the resources or the ability to manage the updating of address information because of the transiency of the population. So that just factors in, number one, does my message get to the client? And number two, even if it gets to the client, because it's written in regulatory language, do they even understand what it is we're trying to say? And it really is incumbent upon the plan to take that regulatory language and take it to a more meaningful, more understandable level of language and messaging to the client. It's one thing to deliver the message. It's another thing that the plan has to do is ensure that it's heard and it's understood.
Absolutely. Yes. Yeah. And and that's such a great point. And And the point about the mailers, we meet with clients and there's just bins of return mail, and there, it's just something that is a headache. But no, every single piece of mail that isn't delivered is an ineffective communication. It did not reach the intended recipient, and it is really important. And I'll get into it a little bit more around the simplicity of the language, because that is so critical, and required in other Medicaid related communications, the reading level and understanding level. So thanks for sharing that.
Yep.
So we were really fortunate from the Usher perspective to be really involved with the Medicaid Health Plans of America organization that has membership from MCOs nationwide. And toward the end of last year, they published a really great Unwinding Best Practices survey. And we got to dig into this. We also were at their annual conference in October and got to dig into this and hear more about it live. So I just wanted to share with all of you what we're hearing from best practices. What is it that's actually working to get the word out and get members to take the needed action? So the number one thing that we were hearing, direct and community connections. So MCOs really getting into the driver's seat and leveraging their direct connections to members, to providers, to pharmacies, to the community footprint, and really just using all of those connections to get the word out in a consistent and simplified way. MCOs are able to connect to those who are no longer eligible to get them to other coverage, or if they were disenrolled, if the data timing is quick enough, they can get back to them with more urgency. Ongoing outreach is key. MCOs that are getting the effective communications out said that the members reached require multiple touch points, multiple channels in order to get their attention. Just like all humans, Medicaid members are busy and distracted, and so it does take an ongoing cadence. Timing really matters. Getting the message out to the members more close to the time that they actually have to do a redetermination action, that they actually have to reapply, not sending it out months in advance and hoping they'll remember. So timing matters. Again, coupling outreach modalities with digital live person calls to augment the mailings that are pretty prevalent. You can go to the next slide. Really, we'll get you all the slides after this. I wanted to throw this chart in here. These are some of the MCO reported unwinding outreach activities that they're doing. Calling, texting, working with providers, public-facing events, paid ads. And the one thing I wanted to pull from this was the number of outreach activities that they're reporting is 7.3. So for every member, they're hoping they will see this message 7.3 times in order to get them to take the needed action. And you can jump to the next slide. This is just, again, tying into what Barry had said. Data accuracy is an Achilles heel here, but the more the states can equip MCOs to support the members, even collecting accurate and complete data, possibly sharing that back with the state or the county, that is really helping. The better data, the more current contact information that any of the entities can get and share with each other, the better. Flexibility was the number one need that the MCOs outlined in the survey, as well as at the MHPA conference. They need greater flexibility in outreach activities, in channels, as Barry mentioned, to simplify the messaging from what has been given to them as required or regulated language around this. There are MCOs and states that are actively working together to improve processes and ensure the coverage maintenance, but we're working with plans nationwide, and it's quite a lot of it is one size fits one. So one MCO may be going to a state or a county for exception approval and they get it. and another MCO doesn't. So I really think it's going to take a concerted effort to get that broader exception and ability to do better communications. The outreach activities, what's here in orange, the extent and details of MCO outreach activities are still really being defined by the states and the counties and the canned language, and it's not working. So I think, Barry, in talking about what do we need to do to make a change so that this can get better, that's one of the really big ones.
Great.
And then the next slide. Alternate communication. There are states and counties that have approved alternate communication language, more simplified language. Barry, even nuances around cultural considerations that really weren't in some of the base language that was approved and passed down from the states and counties to the MCOs. Digital innovations. There was a big panel at the MHPA conference of state Medicaid directors, and all of them indicated that they would be willing to sit at the table with MCOs to look at other channels, other outreach innovations, better campaign language. So I felt that was some positive progress. And I really think in order for this not to be the status quo, in order for us not to be in this, through this unwinding period and beyond, it's really going to take the MCOs seeking and obtaining the exception approvals and being able to make these communications more effective. And this is across all channels. I had just put this in here quickly, some of the things that the MCOs and states say are working, on a pretty regular basis. So the state sending advanced lists of members who are up for renewal with the renewal date to help the MCOs with timing on communications. Being able to, the MCOs being able to send updated contact information upstream. There's such concern from the MCOs about, do we capture it? Then where does it go? Will the state just override it? So there's some progress being made. Sending advanced list at members at risk of disenrollment for procedural reasons, peeling it back a little bit more to really allow the MCOs to give more urgency to those members. And then also getting the list of the members who were recently disenrolled for procedural reasons, allowing the plans to jump back in as quickly as possible. And again, timing is really critical with that one. So just wanted to share some of those with this audience. The number one surprising thing that came out of the survey was how effective it was for MCOs to partner with local providers, including pharmacies. So where these members are going to get their care, having flyers, having educational information, having a way that the members can know that they could lose their coverage for this care, and then links and phone numbers and QR codes with resources at the MCO so that they don't have to, drop and then, figure out how to get the coverage back. So really point of care, a big thing. Community-based partnerships, community-based organization. I got a long list of them here, where the members are, where they are getting the things they need, having the education there right in front of them. And then we do have some MCOs. I showed you some of the more dire news headlines earlier. We do have some MCOs who are working with supportive news media to get the news out and alert the members and let them know where and how to get help. So that is another angle that is really working. So I have one more here. This was one, there's a whole list of things that CMS also published for minimizing the terminations for procedural reasons. And one of the ones I was most excited to see that I know a lot of our plans are pushing for is allowing the managed care organizations to provide assistance to enrollees to complete and submit Medicaid renewal forms. There's one state that is really close, if they haven't done it already, to allowing the plans to actually, help fill out the paperwork and gather some of the information that's needed. So fingers crossed on that one. And so that's really, the market scan of what we've been seeing through MHPA. And now this slide is a bit more on what we are seeing with our MCOs nationwide, as well as a bit of this was validated in the MHPA survey. So we are seeing some really good efforts between states, counties, MCOs, and all the other partners with coordinated messaging. So in California, our clients have been following the state's lead on a watch for your yellow envelope coordinated campaign that California is sending out things in a yellow envelope. The counties are sending things out in yellow envelopes, and the plans are sending things out. It was very coordinated messaging. So that worked in one area. There were other states that where the MCOs and states weren't as coordinated and it wasn't as effective. So I think the more partnership, the better with that. And really what we're seeing, across the US with our MCOs is true hand-holding of the member, very simplifying the language, educating them, getting them the support they need, weaving all your channels together. Mailers that can lead to digital, phone calls that can lead to digital going back to phone calls. So just making sure members have the ability to get help in the channel of their choice. The number one thing that we are seeing is clear, concise, easy to understand messaging and really directive calls to action in the communications. It is okay to tell people that they need to take an action and what that action is, because people are more apt to do what you ask them to do. So that's really working. Not just sending members to complex government websites or physical sites and letting them figure the process out on their own. The more the MCO can explain it, simplify it, help the members find their forms and information they need to take, the better. The community events, and then tying in, Barry, when you were talking about all the different communications and the mail that gets returned, we're really encouraging all of our clients to look at all of their communications, learn and adjust based on what's working and what's not. A huge indicator, if your mailers are coming back, they are not effective. So that just one of the things that we have. So wanted to run through this and happy to answer any questions. But Barry, I'd like to now tee this up because you talked a little bit, gave us a little hint on the new normal. And what is this going to be like and who owns this?
So let me first say thank you. You did a great job of inventorying what the best practices are across the country. Me being a cynic, I'm going to respond to that and say you've seen one best practice, you've seen one best practice.
Yes.
Because it's a best practice in one organization doesn't necessarily mean it's going to work the same way in another.
Yes.
The second thing is that health plans, unfortunately, still focus on extremely narrow, tactical best practices. And this is a huge problem, as we've seen. And I do think it requires us all to take a step back and look at this at a more global level rather than at a tactical level. Mm-hmm. Because you can implement all those tactics and all those best practices and still continue to have a problem. For me, there are a couple of fundamental questions that have to be answered to get us to where I see this future vision. And one is, it's still unclear to me in this ecosystem, who owns the responsibility to work with the member? Is it the state? Is it the providers? Is it the health plan? Is it the community? I'm not quite sure who has been designated that the owner of that process. For me, it's clear. For me, my recommendation would be it's got to be with the health plan. And the reason is health plans already have an existing model in place that they use on the provider side. Providers are required to go through a routine credentialing and re-credentialing process, which is very similar to what recertification is. However, to do that, it's going to require the state and the plan to become partners and stakeholders in making this happen. there's got to be a greater level of transparency between both those players regarding the recertification status and key dates with respect to the member. Again, requiring all three of those players, the state, the plan, and the member, to be part of this. It's clearly in the health plan's best interest to involve the community and its provider network as additional touch points to deliver the message to the member. Again, we've talked about omni-channel of delivering messaging, and most people think in terms of digital, snail mail, email, etc. But there's also a whole other set of resources that can deliver the message to the end user, and that's your provider network, that's your community resources. I think in terms of religious leaders in the community, if we could buy them into our network to deliver these key messages, they oftentimes will resonate more with their constituents than we do. But it's how do we all join forces? And Rebecca, somebody had asked a question early on about when will this end? And my vision, and maybe this is pie in the sky, it's when all the constituents in this diagram really align their goals and sit on the same side of the table with the pure intent of ensuring certification and eligibility of a member, providing good quality care to that member, and trying to optimize outcomes, both in terms of satisfaction and clinical outcomes for that same prospective member. Right now, we're still at odds in many of the cases, and we've got to be able to move beyond that. And until such time, we're still going to be having these conversations about which best practice works. It's when we get to this point in time, then we can apply all the best practices because we will have established an organizational and a structural best practice. That's where I see the world. Yvonne, comments on this?
Yeah, no, 100% agree. And I love your sentiment of, everyone working together. And I agree with you that I think the MCOs are in the position to actually make this happen and push the envelope for the needed change. That's where I'm seeing the most positive progress happening. So appreciate that.
Agreed.
Mhm.
So we do actually have a couple comments in the chat already. So let me read the first question for you. After all the outreach activities, what is the approximate ratio, number of percentage that were converted back to the Medicaid plan?
I can grab that as a start, Barry.
Sure.
What we're seeing in the MCOs that are having the effective communications and interactions, it's coming out in the form of higher renewal rates versus their competitors in the market. So you can look at plan by plan in a market and see the procedural disenrollment as well as the enrollment rate. So we are looking to those numbers, and that's what our clients are looking at as a way of gauging their success in these communications. Again, that really comes down to state data, timely state data being published. So there's sometimes a bit of a lag on that, but those are the leading ROI metrics.
I also think you've already shared the metric that the anticipated impact of this was somewhere between 8 and 28% of enrollment?
Yes.
Those are big numbers. So the converse of that would be the nominal amount of retention, and you would hope that with efforts you can increase the retention rates even further.
Absolutely. Thank you.
So what are you seeing MCOs doing to get relief and exceptions from states and counties to enable better beneficiary communications?
I can grab that. And just from what we're seeing across our accounts is taking, as Barry said, ideas of what is working in other areas of the plan, innovative ways of communicating and estimating, first of all, showing the state and showing the county what that different experience would look like, the interactivity, the hand holding, as well as then being able to show where they think they can make a difference in the ROI. So it's quite data driven. Here's what we think we can deliver better, tying back to that last question, through different means of communication, being able to use different language, friendlier language, culturally considerate language. So that's really what we're seeing. And it is, Barry, you said one size fits one. So much one size fits one here. We have two plans in the exact same county, exact same state. One's getting an exception, one is not. So it really is taking the MCOs pushing and driving for change, because what is working status quo is not getting anyone the results they need.
So we have another question. We are sending one-way SMS text to beneficiaries for recertification, but don't enable them to reply or interact. Are you saying that MCOs are actually using a digital tool that supports interactivity for recertification?
We are, yes. So the one-way push, and we've seen a lot of client data with one-way push of information, whether it be a one-way mail or a one-way call, a one-way digital text. And then when you bring in interactivity and the ability to allow the member to respond and give you answers to questions and find a community event on a map, that's where we're really seeing the activation, the engagement, the action that members are needing to take.
Looks like I have another question. Now that we are here, what do we do to find ourselves in the same predicament?
I'm thinking that might be not find ourselves in the same predicament.
I think you're right.
So
Yeah.
How about, you want to grab that?
Oh, sure.
Many things.
Yeah. I think constantly challenging the plan and constantly talking to your clients and asking how you can improve your ability to communicate, deliver messages to them. It's one thing to be able to tick off on a compliance check sheet that I've sent out the notification. It's another thing to reach out to the client after the notification, ensure that they've heard it, seen it, understand it, and most importantly, acted on it.
Yes.
There are so many things that need to be done. At the executive level, I think reaching out to the state to start discussions around how do we collaborate around the clients we serve. I think at the operational levels within the plans, we have to start looking at not just the communication to the members, but equally as important is communication within the plans between departments, because oftentimes it's like the kids' game. The messages get convoluted from one site to another. Actions get wrong, and we end up pushing in the wrong direction within the organization. We need to start looking at call centers. Why are people calling in? Look at trend analysis and not deal with the issue in terms of the actual caller, but in terms of what are the systemic changes that need to be made to improve the issue, to prevent the call from needing to be made. And the last thing I'll leave you with is the question, because it's such a great question. I could go on for hours. The real question here for all of us is, how do we get in front of the problem? We don't want to be reactive and deal with the results of the problem and the fallout of the problem, but how do we get ahead of it? How do we prevent clients from losing certification? What are the action steps that we, and when I mean we collectively need to do to ensure continuous eligibility for that client? And we need to be more proactive in developing solutions and approaches rather than the reactiveness. Hopefully that answers what you're asking for.
Yep, couldn't have answered it better myself. Also could go on for a lot longer, but appreciate that. Thank you.
Yep.
Any other questions, Rebecca?
Looks like that's all the questions we had in the chat. So I just guess I'll just want to thank you guys. Thank you to everyone for attending today's webinar. And a special thank you to Yvonne and Barry for your attention to this important topic. As a follow-up, Usher will be sending each attendee a recording and a PDF of today's presentation. If you do have any follow-up questions, specifically Barry and Yvonne's contact information is on the screen at the moment for you. But thank you again for all your participation in today's event.